Thank you, everyone, for joining us for London Health Sciences Center's October 2025 Community Update Meeting. Before we begin, I'd like to turn things over to Dr. Chris McIntyre, who is LHSC's Interim Vice President of Research and Scientific Director for London Health Sciences Centre Research Institute, to deliver today's land acknowledgement. Chris?
Thanks very much, David. Victoria University and Children's Hospitals are situated on the traditional territories of the Anishinaabe, Haudenosaunee, Lenape, and Chinootan nations, on lands connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. We acknowledge our neighbouring Indigenous communities, the Chippewas of the Thames, the Oneida Nation of the Thames, and the Munsee Delaware Nation, who continue to be sovereign nations and thrive with their own unique languages, cultures, and ceremonies. As a nephrologist at LHSC, my job is to look after people with kidney failure. People from Indigenous communities suffer very high rates of the medical problems which typically lead to kidney disease. This burden, in combination with systemic failures to acknowledge and appropriately address these challenges, have resulted in large numbers of people clustered even within small communities having to live with the physical, psychological, and financial difficulties associated with having to have their blood cleaned by kidney dialysis. For me and other members of the team, this acts as a daily reminder of the ongoing need to value and respect Indigenous ways of knowing, being, and healing to better serve our patients, and to actively participate in the larger journey towards truth and reconciliation that we reflect in every aspect of the care that we strive to deliver.
Thank you, Chris. So for those of you who are tuning in for the first time, welcome. Our community update meetings serve as a platform to keep you informed about what's happening within our organization and share updates on any new initiatives LHSC is participating in and outline the steps we're taking to deliver on our promises of providing excellent care. These meetings are live streamed through YouTube, and a recording is also made available afterwards. Our meetings also replay on Rogers TV London. So today marks our first community update meeting after our summer pause, and it's great to be back connecting with all of you. Just a refresher, when we launched these meetings last fall, our goal was very simple. We wanted to strengthen our connection with patients, families, and the broader community, and create a space for open dialogue, transparency, and accountability, a space where you could hear directly from leaders across LHSC and where your questions could be answered. Over the past year, we've seen the forum grow and evolve. Through your engagement and feedback, these meetings have become an important part of how we share progress, celebrate achievements, and discuss challenges and opportunities ahead. In fact, we've seen close to 4,000 unique individuals watch the meetings online, and this doesn't even take into account how many people see it on Rogers Cable. One new addition I'm excited about is our Did You Know segment, where we'll be highlighting insights about LHSC that you might not know about. So as we look at the months ahead, we'll continue to highlight the work happening across LHSC. So I want to highlight a few topics myself before I hand it off. And again, I want to thank everyone who continues to tune in. So if you recall, almost a year ago, we introduced LHSC's Community Advisory Committee. Our CAC is a way to strengthen connections between LHSC and the people we served. The CAC was formed to bring a diverse perspective from our community directly to our leadership team so they can make informed decisions, improve operations, and ensure our work reflects the needs of the people we serve. Over the past year, the CAC has been very busy at work. They've provided thoughtful advice on a wide range of topics, and they've taken an active role in shaping LHSC's direction. This has included conducting surveys both in the community and with LHSC staff and physicians, helping us gather valuable insights and informed important recommendations and actions, and I'm going to be providing an update to you. So I want to take a moment to thank our past and current CAC members for their time, insight, and dedication. To those who moved on from the committee, your contributions have been invaluable, and I really want to thank you. We're also pleased to welcome our new CAC members whose voices and perspectives will strengthen the work moving forward. You can learn more about our members and read their stories on our website. In the coming months, the CAC will continue its work, including advancing recommendations from the surveys, exploring new ways to connect with our community, and helping guide initiatives that matter most to our patients, families, and our team. This committee is making a real difference, and we are grateful for their partnership. So the CAC recommendations, what resulted from the feedback you in the audience provided on the surveys, are an important part of LHSC's improvement journey, and they tie in closely with the recommendations we received through the detailed organizational review that was completed earlier this year. This review, led by an independent third party, looked closely at everything from our leadership governance and how we manage our finances to how we run both our clinical and non-clinical program. As reported, there was a total of 169 recommendations aimed at improving how we lead and manage our hospital. To keep everything moving forward cohesively, we're tracking the CAC recommendations together with those from the detailed organizational review through a single master work plan. Many of the CAC recommendations complement and align with several recommendations from the organizational review. Each of the 169 detailed organizational review recommendations has been assigned to a most responsible person who is responsible for the implementation. These individuals have formed working groups to lead the work, and in some cases, a single group is taking on more than one recommendation because they're related. Just to give you context, we have in total 62 working groups that are comprised of over 800 frontline LHSC staff who are actively working on each recommendation. That's pretty impressive. The CAC recommendations have also been assigned to a most responsible person, although not every recommendation will move forward through a formal working group. Instead, these individuals are advancing them in ways that make the most sense for the respective areas and also the organization as a whole. So looking at the big picture where we stand currently with the CAC recommendations, out of 29, 2 are totally complete, 23 are in progress, and 4 have yet to start. And where we stand with the detailed organizational review, as you see, there was 169 total recommendations, 62 working groups that have focused on addressing them, and to date, 14 have been completed, 57 are in progress. This is a snapshot of the current progress. And again, even with the recommendations, they were not meant to be done in like days. These recommendations put forward over a 3-year implementation plan, and we're on target and where we should be with respect to the implementation. So again, kudos to the over 800 staff who are directly involved in making this happen, in the CAC committee for also making it happen as well. So one of the issues we need to talk about is, as we continue our journey, is it's also important we speak openly about some of the challenges we're facing. Since this is our first meeting since a summer pause, I want to take a moment to address our ongoing investigation into past procurement practices. Over the summer, we filed 3 statements of claim related to past procurement practices and negligence and vendor project completion at LHSC. When I became and was made aware of some of the concerning information, that's when I engaged the London Police Service to investigate. At the same time, we opened an internal forensic audit conducted by a third party. During our internal investigation, we identified past fraudulent activity, which LHSC, regarding procurement practices that occurred over the past decade and plus. We also determined that previous members of LHSC's executive team had been alerted to these practices and did not take appropriate action. As a result of these findings, LHSC filed 2 statements of claim earlier this past summer. A third statement of claim was filed more recently, and it is against several vendors and individuals for negligence in a large-scale project to replace windows at University Hospital. This was one of the projects that was identified in the earlier statement of claim and shared in July. While investigations are still ongoing and the full extent of the deficiencies is unknown, we have identified issues with the quality of the installation. To date, we have not experienced any safety issues related to these windows, but we continue to work with our external experts to assess the deficiencies in greater detail, and any safety concerns will be addressed immediately. So as we pursue these civil cases and continue our forensic audit, we also provided findings to LPS, who will continue their own investigation. These statements of claim reflect our commitment to ensuring those involved in past procurement practices are held accountable, and to strengthening our oversight and governance in operations, in policies and procedures, and financial practices. So I've been asked, what are we doing to make sure this doesn't happen again? Over the past year, LHSC has taken significant steps to strengthen governance, oversight, and accountability across the organization. We are committed to building a culture rooted in transparency, responsibility, and continuous improvement. Here are some of the specific actions we've taken to reduce the chances of this happening again. I don't want to come across that this will eliminate this from ever happening again. Anyone who says that's not living in reality. What cannot happen again is for an event like this to happen and happen over such an extended period of time. That's got to stop. You got to put in checks and balances in place in order to ensure it doesn't last for a decade or more. So we have developed and started implementing a multi-year internal audit plan supported by both the internal audit team and external expertise, KPMG. This includes third-party reviews and enhanced internal controls across financial and procurement functions. We've also overhauled our financial and procurement policies to ensure stronger controls and greater accountability. Clear standards and processes are now in place to guide decisions making in order to reduce or prevent this abuse. This has also been communicated to all staff and professional staff, and we're focused on ensuring adherence, and that's where regular monitoring of adherence to the policies and procedures is critical. Also, something new, which is unique, is we have a vendor accountability program that's been implemented. Vendors are required to submit annual conflicts of interest declarations committed to anti-kickback rules and disclose any fairness-related concerns as conditions of doing business with LHSC. There's also, as you're aware, we did a comprehensive executive restructuring, and I'm working with external experts to modernize the board of directors bylaws, committees, orientation, and oversight responsibilities. Future board members will have a clear mandate to enforce rigorous compliance standards when the board is eventually renewed. And we recently updated our whistleblower policy to reinforce a safe and anonymous mechanism for staff and stakeholders to raise concerns without fear of reprisal. These changes reflect a fundamental shift in how LHSC, one rooted in integrity, transparency, and responsible stewardship of public resources. Before I turn it over, one last thing I want to share about is an important safety update from across our hospital sites. As you know, early this year, we introduced new weapons detection systems at the entrances of UH and Victoria Hospital and Children's Hospital emergency departments. You'll see these systems in place at both sites if you visit, and the security team is present to support you as you enter the facilities. These systems are making an impact and represented a major step forward in keeping staff, physicians, patients, and visitors safer from the moment they arrive at our emergency departments. As stated, nothing is 100%, but it adds another significant layer of security for our staff, patients, and visitors. So at University Hospital, the technology went live April 15th. We've identified the biggest item is knives, 601 of them since April. That works out, if you're doing the math, to approximately 3 knives a day. As stated, what we saw was an influx at the start. It's come down and it's sort of settling at this 3 a day. The system at Victoria went live May 6th, and since then, there's been 861 knives identified, which works out to 5 a day. In all these cases, individuals either turn these items over to security team or return them to their vehicles. In addition, prohibited items like illegal knives, batons, pepper, bear spray, and we found a homemade taser, are provided to police authorities. I've said this before, but we got to repeat it. In 99.9% of these cases, the individuals who bring these items in have no ill intent with them, bringing them into the emergency department. However, they simply don't need to bring them in with them when coming to the emerge. It's kind of like the same thing when we were all going to airports in the past and they didn't have metal detectors or they weren't as sensitive as they were. We brought on a whole bunch of stuff with us, and it took time before we learned when we go to the airport, you don't need that stuff. Same with an emergency department. Leave it at home. You don't need to take it with you. So what's encouraging is the feedback we're getting from both staff and patients. The process is smooth, respectful, and helps create a safer environment. And our security teams clearly continue to play an important role in making this happen, helping people through the process, answering any questions along the way. And I really want to thank them and the teams involved for helping us. So now you've heard enough from me. It's time to move into the presentations. I'm going to hand things over to Deborah Wiseman, who's our VP of Medicine, Emergency Services, Critical Care, Clinical Neurological Sciences, and our Corporate Nursing Executive, as well as Dr. Christy McDonald, who's our Interim Vice Chair of LHSC's Medical Advisory Committee and Department Head of Emergency at LHSC.
Thank you so much, David. On September 12th, LHSC proudly came together to celebrate a truly remarkable milestone, our 150th anniversary. It was a day that reminded us not only of how far we've come, but also the community that has supported and shaped us along the way. Across Victoria Hospital, Children's Hospital, and University Hospital, our staff, physicians, volunteers, patients, partners, and community members gathered to mark the occasion. Guided tours, historical exhibits, all provided glimpses into the many chapters of our story, from the early days of London General Hospital in 1875 and through the decades of growth to the world-class care we deliver today. It was a day to honor our history, but also looking ahead with optimism. Guests had the chance to explore our exhibits, to learn about our history, to tour some of the program areas, and experience live demonstrations, including the cardiac bypass system and our surgical robots, which usually are tucked behind areas not available to our community members. These are powerful examples of the innovation that continues to shape healthcare in LHSC. The celebration also brought together leaders, physicians, educators, community partners, who all shared thoughtful reflections on LHSC's enduring legacy of exceptional care, teaching, and research. Together, we highlighted the many ways this organization has touched lives, advanced health across London and Ontario, and well beyond. Most importantly, this day was a chance to celebrate the people who make LHSC the place it is today, the dedication and compassion of our teams, past and present, that have carried us through 150 years, and it is that same spirit that will guide us to our future. Another exciting celebration took place in September. It was a month of celebrations, actually, and this was a truly special day as well, as we gathered to honor the incredible milestone of long service. The day gave us the opportunity to come together as a team to recognize the dedication, compassion, and commitment of colleagues who've reached 10, 15, 20, or 25 plus years of service. We were very excited. We had this year a few members that reached 45 years and even 50 years of service. Incredible commitment was celebrated. It was more than an event. It was the reflection of the heart of our hospital, the people who make us who we are today. Whether at the bedside or behind the scenes, these team members shape the care we provide every single day. And I want to thank them again thank everybody who joined us for the celebration. The presents that day made even more meaningful for the celebrants. To our award recipients, thank you once again for your years of service. Your dedication is inspiring, and we are grateful for the incredible difference you make every single day. Before I hand it over to Dr. McDonald, I'll just share, and it's a challenge I'm laying down. We won last year the Canadian Blood Services Hospital Challenge, and this year we're ready to roll our sleeves back up and once again take that trophy home. Our goal this year is to donate 150 units of blood by October 31st and keep that first place trophy. Blood, very importantly, plays a critical role in everyday medical care at LHSC. It's essential for our surgeries, our cancer treatment, our chronic illnesses, and our traumatic injuries that our patients need from us every day. Anyone can donate on behalf of LHSC, so now is your time to join the team. Staff, physicians, learners, volunteers, already waiting for our community members to join us. All you need to do is join the LHSC team online, check your eligibility on the Canadian Blood Services website, and book your appointment at one of the many donation locations across London and Middlesex. What a fabulous way to join LHSC as a team. Over to you, Dr. McDonald.
Thanks very much, Deborah. I appreciate that. And the challenge is on for sure. Many of us in our families or our friends have been touched by kidney disease, kidney failure, and dialysis. Dialysis is a life-sustaining treatment for millions of people with kidney failure, but it can also bring quality of life concerns. And although it works almost as well as a kidney, it doesn't work quite as well as a real kidney. While transplants remain the best option, long waits and eligibility criteria mean that it's critical to improve dialysis itself. That's the goal of a very cool study in which we're involved, the goal of DIALEX. It's a 5-year, multi-center randomized controlled trial that will include up to almost 5,000 patients across more than 100 dialysis units in Canada, including our London Health Sciences and our satellite sites in Chatham, Goderich, Hanover, Owen Sound, Sarnia, Stratford, Tillsonburg, and Woodstock. Patients are randomized to receive either the standard dialysis filter or a newer type. The study will compare survival, heart problems, and other outcomes such as hospitalizations, symptom management, to really see if the new filter does improve quality of life. Quality of life is really what's important to our patients and their families. By including our regional community hospitals, this study also ensures patients in rural areas can participate without needing to travel. This patient-first approach will help make findings more representative while offering access to treatments patients might not otherwise have. This study is funded by the Canadian Institutes for Health Research and Western University's HDRN Pragmatic Trials program, a very exciting trial ahead for our patients. 'Tis the season for viruses. As we head into respiratory virus season, public health experts in our region are encouraging everyone to consider vaccination. It really is one of the best ways to protect yourself and protect those around you. Starting October 27th, there will be free flu and COVID-19 vaccines available across Ontario, with certain high-risk groups eligible even earlier to receive their vaccination. This certainly helps ensure that they're protected before virus activity peaks. The RSV, or respiratory syncytial virus vaccine, is also now available for specific groups, including babies and young children, adults over 70, and those who are immunocompromised. These vaccines can be accessed through family doctors, pharmacies, and the Middlesex London Health Unit clinics. For children under 4 years, the Middlesex London Health Unit offers these vaccines directly. For families, it's important to note that children 6 months and older are strongly recommended to receive their flu vaccine each year to help reduce illness and complications. And the good news is, all 3 vaccines can be given on the same day, making it easy to get comprehensive protection as we head into the season. And of course, vaccinations are one piece of keeping each other healthy. The other piece is stay at home if you're unwell. Lots of hand washing and eating and sleeping well as we head into the holiday season and virus season. Now, a little bit about Children's Emergency Department. We're very, very privileged in London to have a dedicated, specific Children's Emergency Department. With the return of school, we wanted to take a moment to remind families of where they can go if their babies, children, or teens require emergency care. At LHSC, Victoria Hospital is the only site with a dedicated children's emergency department. University Hospital does not provide pediatric emergency services, although we do provide care to children and can provide the support over to our pediatric emergency department as well. The children's ED is open 24 hours a day, 7 days a week, and is located right next door to the adult emergency department at Victoria Hospital. We also offer virtual urgent care for non-life-threatening issues when families can't access timely care through a primary provider. Our goal is to help families feel confident about where to go, knowing that specialized pediatric emergency care is always available for our city and our region through our children's emergency department. And finally, happy Halloween. As Halloween approaches, we want to remind everyone about safety, both on and off the roads. Trick-or-treaters will be out on October 31st, and it's important for drivers to use extra caution in neighborhoods. Families can help by making sure both big kids and little kids wear bright colors, that their animals and kids are wearing reflective costumes, and carrying flashlights or glow sticks to stay visible. Make sure kids travel in groups, stick to sidewalks and crosswalks, and not to rush across streets. And as always, check the treats before eating them. We hope everyone has a very safe and fun Halloween. With that, I'll hand over to Dr. Chris McIntyre, the Interim Vice President of Research and LHSCRI Scientific Director.
Thanks very much, Christy. Thank you for the opportunity to update the community on some of the amazing research work that's going on within the hospital, within the Research Institute, as well as to give you an update on the investments and the changes we're making in the Institute to do more research better and service our patients' need more effectively.
You're on mute, Chris.
There we go. I'm a Canadian by choice and a Londoner by choice. I came here 11 years ago, having previously been head of a medical school in the UK in Nottingham. I'm a kidney doctor, and I have a long history in many different kinds of research. And now I have a position as Professor of Medicine, Pediatrics, and Medical Biophysics at Western University. And I've been in my current role since May of this year. In many ways, though, the most important part of my CV more relates to this image here. This is Christopher. He's our youngest son. He was born in 2015. He was born here in London, and he has Down syndrome and was confronted with a series of very serious medical challenges, certainly the first year or two of his life. We were lucky that we received university exemplary care here at Children's Hospital and in ICU. And as you can see now, there's not a lot wrong with him, other than the fact he likes to hide in buckets. Through the period of him being ill, though, it made me and my wife, Natasha, ask ourselves some very hard questions about what was it that we were here in healthcare to do, and particularly with research. And I'm experienced clinician. I've looked after kids with cancer, leukemia, heart transplants. And up to this point, I thought that just providing the best care you can and explaining it in the best way you can is enough for people. And this made me realize that actually it's not. So we come to the challenge of thinking about what is healthcare for, and particularly what is hospital-based research care for. So what is it that people need? And I think the important part is that everybody are just that. They're people. They're not patients. And people are united in the need to feel safe. And that doesn't matter if you're in a cave, you're in a relationship, or you're in a cancer ward waiting for your treatment to start. And research plays a core issue, both in making people feel that they're safe, that they're in a place that is looking to make their care better, but also to evolve that care to make them materially safe. So as we evolve the Research Institute, we have three key components. We want to increase the number and quality of external trials that come from academic partners and from industry, because that gets our patients the best and the newest treatments. We want to maintain the cadre of scientists and faculty we have here who are doing discovery. They're inventing new things, new insights, which will become the new treatments of tomorrow. And we need to support all members of the healthcare team so they can access the best processes of care and examine and investigate and share how organising that care works best. And the thing about London is we're big enough to matter, but we're small enough to be manageable. And so we need to be agile and responsive to our patients and our research community. So I'd just like to share some research milestones really over the last year or so, just to give you a flavour of what's going on. These are 7 case studies from the 2,300 projects that are already going on. We're already highly research intensive. We've launched the first clinical trial using poop pills, actually taking fecal matter from healthy people, treating it in a special way, and using that to repopulate the bacteria in people's guts with pancreas cancer so they can respond better to their treatment. Other researchers have looked at the myths relating to the viral mouth taping trends, debunking the benefits and demonstrating the potential harms. You've already heard about research looking at a new kind of dialysis filter, but also providing information for patients and clinicians to better have conversations about the risks between cannabis use and mental health issues, psychosis in particular. There's additional work improving the quality of life of people with common problems such as osteoarthritis, and new ways to treat radiation by embedding radioactive beads inside the patient, allowing the dose of radiation to be 10 times higher, but without the external damaging effects of that radiation of not being in the right place. And finally, research looking at improving detection of hidden blood clots in people with strokes so their outcomes can be improved. So it's a year tomorrow to when we launched LHSCRI as a separate entity. And we spent that last year examining ourselves very hard and working out what it is we can do to evolve and change. This work is going to be involving profound alterations in both focus and how we set about it. It'll provide more access to more clinical trials. It will improve the support to all of our researchers and will allow us for the first time to establish a research unit open to all researchers to use, so nobody who has an idea will not be able to use that for patient benefit because they can't access resource. So what does this all mean? Well, it's LHSC, it's London Health Sciences Centre. Science is actually in the middle of our name on the side of the building, and we need to live that. We know that research-intensive hospitals and patients participating in research do better than patients who don't have access. So that means we have to retool everything to allow the largest number of patients to have access to the latest cutting-edge treatments and trials. Put simply, the more we invest in research and the more we tie it into the hospital's core mission, the more of our patients will benefit more effectively. So with that, thank you for your time, and I'd like to hand on to Dr. Nadeem Khalil, who's the lead for infection prevention and control for the Children's Hospital.
Thank you for that introduction. As the respiratory season is upon us, we want to take this chance and opportunity to make sure everybody stays safe and healthy, both in the community and at the hospital. We do expect an increased number of cases starting now. We have already seen a few cases of COVID, both in the community and at LHSC, and we do expect influenza cases to increase starting November till the end of spring. I do want to note that Australia recently had one of their worst influenza season in the last decade. This could represent and predict a potential hard season for us as well. Same thing for respiratory syncytial virus, or RSV, is a bad infection. It affects young children less than 1 to 2 years of age, as well as older individuals older than 75. It's a frequent number because of admissions in young children, which can be quite devastating. Talking about COVID, even though the numbers have gone down quite dramatically since the beginning of the pandemic, we are still seeing quite a few number of cases. It's as severe as influenza, and sometimes part of the year is even higher number of admissions. And unfortunately, it's hard to predict. We don't have yet an established seasonal pattern as we see with influenza and RSV. And I do want to note that we have already seen an increase in number of cases this fall, with increased number of admissions and as well a few cases of mortalities in London and Ontario. The most important thing we could do to keep people safe is the vaccine. And I do want to really emphasize that these vaccines are quite effective and safe. In previous years, people with chronic medical problems, children less than 5, those older than 65 have an increased risk of severe infections and needs for hospitalization. While the vaccine might not prevent every illness, they have been proven to reduce severe symptoms, needs for hospitalization, needs for intensive care, and most importantly, does reduce the risk of death. Getting the vaccine will not get you sick. It's safe, it's effective, and has been proven across billions of people have taken it around the world. It does not contain any harmful ingredients, does not cause autism. The good thing, it only gives you a small part of it. It's as you imagine going to an exam and you've had the exam given to you ahead of time. Your probability of doing much better on that exam is way higher if you've studied for it. The other reason I want to talk about the vaccines is it does produce bad cases and bad disease. In the last few years, there has been increased trends of severe brain disease in children who are previously healthy. We've seen that happening after COVID and influenza. And despite the best treatment and support, these cases frequently end badly. Again, the good thing, vaccines have been shown to reduce the risk of those severe infections. So what kind of vaccines are available for you this year? Like Dr. McDonald was just talking, we do recommend everybody getting their flu and COVID vaccine as soon as possible. Those at high risk to be sick, those with medical problems, young children, older individuals can get their vaccine as of now. For the rest of the general population, you can wait till the end of October. The good thing, again, Ontario Public Health has funded these vaccines to keep people safe. The other one for RSV, we do give a passive vaccine for young children when they're born. So those that were born recently in the last few months can still get them through their family doctor. But those that are above 75, can still get another vaccine booster to help them safe. And the other one I want to talk about is the pneumococcus vaccine. Pneumococcus is still one bacteria that's the one that causes a lot of bad infections in healthy individuals and those with medical problems. The vaccine is routinely given to all children, but we do recommend also a booster for older individuals or those with medical problems. Finally, what can you do to keep safe this winter season? We highly recommend everybody getting their vaccines, wash your hands, and stay away when you're sick. We'll do the same. We're starting our vaccine. I'll talk more about that next couple of slides, but we are recommending our staff and volunteers to get their vaccines. We will stay safe, stay at home when we're sick. We will wear protective equipment just to make sure we don't get sick and don't get any of other people sick, and we'll wash our hands frequently. Starting October 20, we are starting our LHSC seasonal vaccine campaign. Staff and volunteers can get their vaccines at both UH and VH, and you can get both influenza and COVID vaccine. And so everybody needs to do their part, both staff, visitors, patients, and volunteers. So please get your vaccines as soon as possible through your pharmacy, talk to your providers and public health, and as well encourage your families and friends to stay up to date on their vaccines. I'll take that opportunity then to move on and pass back along to Jennifer Rasco, Director of Emergency Medicine, and Dr. Christy McDonald, to talk about Nurse Police Response Team and Geriatric Emergency Nurse.
Thank you for that introduction. The Nurse Police Response Team was developed in collaboration with the London Police Services to strengthen our partnership and deliver necessary services to the community. On July 6th of this year, we started a rollout of the program Fridays and Saturdays from 11 in the morning to 11 at night. And then as of August 15th, we rolled out 7 days a week. The team involves one registered nurse from the emergency department and the foot patrol officers who respond to a specific set of calls that roam the downtown core, providing medical assessment and support along with resources related to homelessness, addictions, and under the London Police Services Pathways Initiative. The Nurse Police Response Team addresses social determinants of health, barriers to housing, and healthcare services, and offers and helps resources where wanted. We're meeting the individuals where they are without having to come to the emergency department, as many of these people do not access the emergency departments, however, have significant healthcare needs. London Police Services is appreciative of the additional resource and the support that the nurses are able to provide to this population, the increased engagement and capacity to care. Along with our community partners, as a team, we're addressing many social, mental, and physical concerns that these people have. The Nurse Police Response Team model is similar to the one in Windsor, where we emphasize kindness, compassion, engagement, and safety for the greater community. Over approximately the last 60 days, our team has had 213 patient encounters. Approximately 5% of those were repeat persons who required some sort of engagement or assistance over multiple days. Majority is for ongoing wound care supplies and dressing changes, which have shown significant improvements in the status of wound progression among the team, preventing emergency department visits and hospital admissions. The person is always offered a visit to the emergency department, but many of them refuse, noting stigma and previous trauma. Feedback is always appreciative of the access to resources, as the use of many resources as many use the Intercommunity Health Program, but aren't able to access it daily. London Police Services has assisted in the administration of naloxone, where nursing has been able to support the assessment and our paramedic partners transport to hospital. Over the next steps, we're going to be reviewing feedback from our frontline, our patients, and our community to highlight gaps in resources. We are collaboratively creating an education plan to fill current education needs for nursing and looking at the future gaps, and advocating and educating for winter weather considerations for housing and access to people, as they are no longer maybe on the sidewalks, but still require our resources. I'm going to hand it over next to Dr. McDonald to share the information on the emergency department geriatric emergency medicine nurse.
Great, thanks very much, Jen. So as our population in our community ages, we're seeing more patient presentations relating to adults who are in their elder years. Approximately 30% of our visits would be classified as patients in their elderly years. We know that illness complexity increases as we age. We also run a higher risk of hospital admission rates, potentially a longer length of stay, and certainly a risk of functional decline. And I think that's what we're all concerned about in our patients and in our family members, is that functional decline. Often emergency department visits are the first time a patient enters that signals something may be changing in their wellness, in their well-being, and in their physical health. By providing specialized frailty-friendly services in emergency departments, the decline and loss of independence can often be prevented or certainly delayed, and it decreases the risk or the risk of repeat emergency visits or that first ED visit. We are exceedingly lucky in both of our EDs to have our geriatric emergency nurses. These are skilled emergency nurses with advanced clinical training in the care of the elderly, which is classified as geriatrics. They have a huge knowledge base of community resources that are very, very beneficial to our patients and their families. We have had geriatric emergency nurses for about 15 years. We have sort of been ahead of the curve and have enjoyed this service over the last 15 years. They work Monday to Friday, daytime hours, but do a great amount of work following emergency visits as well. Their primary focus is on patients that are being discharged who are living at home alone or in a retirement home. Our geriatric emergency nurses assess elderly patients coming into the ED, and often make that linkage with their family to get a broader perspective of what is happening in their lives. In collaboration with the emergency physicians, the nurses, the GEM nurse integrates the care of the elderly principals to complement the delivery of emergency care. Our GEM nurses support care for older adults by sharing knowledge and skills. They act as a resource person and collaborate with the entire team. After discharge is a very, very important time for our patients and their families. Our GEM nurses play an integral role in ensuring that patients discharged from the emergency department are linked with all of the community supports that they need. They contact patients to ensure that patients and families understand the discharge plan and review again any discharge instructions that were provided by the emergency physician. This is exceedingly important, particularly if there are any memory difficulties or any impairments that a patient may not completely understand instructions and disposition planning. They'll also make the connection to ensure that there are no new concerns or worsening symptoms. They also, again, link patients and family givers with community resources to help with caregiver burnout. We know that as we age, it really is a family affair. Our GEM nurses link emergency department patients and their visits with their broader circle of care, including family physicians, community pharmacies, and Ontario Health at Home, which was previously called CCAC or the Southwest LHIN. We also can do specialist referrals, and often GEM nurses may recommend or facilitate referrals to physician specialists at LHSC or St. Joseph's Parkwood to our geriatric medicine or geriatric mental health team. We are exceedingly lucky to have our geriatric emergency nurses, and they certainly play an integral role within our team. With that, I'll hand it over to Narissa Taylor for the virtual care program. Narissa is the manager of operations in virtual care and My Care portal. Over to you, Narissa.
Thank you, Christy. Hello, everyone. Pleasure to be here. I'm thrilled today to talk about the virtual care program and work going on within virtual care at LHSC. Just to get started, I did want to go over what a virtual healthcare appointment is. This would be when you have an appointment with a healthcare provider, and instead of coming to the hospital to see them, the appointment is taking place where you are at home or with a caregiver, and it is happening over telephone or over video with a smartphone or computer. That would be one type of virtual care. There may be other types of virtual care like text messaging with your healthcare provider or email communication. It can even look like monitoring your health while you are recovering at home, which we are calling remote monitoring. So there's many different aspects of virtual care. Today, I'll be mostly concentrating on the telephone and video appointments. And just it's important to note that virtual care appointments are not appropriate for every medical need. And my classic example is you can't have an MRI virtually at this time anyways, not today. So some appointments do require in-person presence. However, these types of virtual care appointments are now becoming part of the standard of care at LHSC and are available when clinically appropriate and patient preferred. So just to give a bit of a background about the virtual care program, this program began in May around the pandemic timeframe, became a permanent program in April of 2023. And it's intentionally actually a joint program between LHSC and St. Joseph's Healthcare London. And that was done intentionally because we use the same technology infrastructure across both healthcare organizations. And we wanted to make the experience more streamlined for patients and caregivers who are accessing technology to join their healthcare appointments. This program is also co-designed with patients and caregivers, and we provide support both for the organizations as well as staff and patients and caregivers as well. We've certainly had a lot of positive experience with patients who've had the opportunity to do a video appointment. In fact, out of our survey responses, 91% of patients or caregivers say they are satisfied or very satisfied with their virtual care experience. And I just wanted to highlight two stories or two examples of patients who've had great benefit from using virtual care. So this is John. He is a patient of the LHSC Orthopedic Surgery Clinic, and John lives in Port Elgin, which is about a 2.5-hour round trip to London in order to access his healthcare appointments in person. So John had an upcoming third knee surgery, and he was able to actually complete all of his preoperative appointments from home, as well as his preoperative education classes, and he found it was quite a great experience and helped reduce his need for travel. Another great patient experience or positive experience is for 11-year-old Noah here, who has been diagnosed with type 1 diabetes. And as you can imagine, a chronic disease like diabetes can require frequent appointments to help with management. His mother, Julie, was quite challenged to keep up with the in-person appointments, and she accepted the offer to switch some to virtual. She found the switch to a virtual appointment was less stressful for herself and Noah while still receiving great care at LHSC. We have also completed a year in review report, and the QR code is here if you'd like to scan. It is available today. This is a report that summarizes the program highlights from the last year, what we are working on this year, and what remains on the horizon in virtual care. And I did just want to highlight the numbers in that poster as well that show in the last fiscal year, we had almost 200,000 virtual appointments. That was telephone or video appointments. And that does correspond to a lot of actually travel cost savings for patients. And we can calculate that because we know the distance of travel required to come to an in-person appointment for a patient. So in the last fiscal year, this saved patients $15 million in travel-related costs, as well as almost 22 million kilometers of travel. It also has environmental benefits, as there is no need to displace patients to come to the appointment. So that did save 5,800 metric tons of CO2 emissions avoided as well. So I would encourage you to take a look at that report. And I did want to also mention a new role or newer role that exists at LHSC, because we're now asking patients and caregivers to leverage or use technology in order to get to their healthcare appointments or in order to connect with their healthcare providers. We recognize that this can introduce equity gaps for people who don't have access to technology or maybe don't have the comfort in using technology. So we did create a new role called a digital navigator. And that role is specifically meant to help with patient support, patient technology support. This can help to close the digital divide. So if you are interested in trying out video appointments for yourself or a loved one, and you need some support, you can definitely contact a digital navigator and they'll help you with getting connected and getting set up. I did just want to go over to a video of the digital navigator with supports.
Hi, I'm Corinne and I'm a digital navigator. Our role is to break down barriers for patients.
A patient has an appointment with a doctor, let's say tomorrow. So I call them today, 24 hours before the appointment. I explain the process of what we're going to be doing. Then I schedule a test trial with them. Send them an email, they join the meeting, we test the audio, we test the video.
Ruth was my wife and she lived with vascular dementia and Alzheimer's. Most of our appointments, follow-ups to that, were done using virtual care. And at first I was really apprehensive about it because it was all brand new to her. And to try to teach somebody who lives with dementia a new way of communicating is a little bit awkward. She loved it because she didn't have to go anywhere. She could stay at home where she was comfortable.
We basically would be able to see our whole team too, all at once. Yeah. So if we had a question for one team member compared to another team member, we could just, automatically say it.
I was able to connect to so many different people and so many different professionals. It just opened up the world for me.
We're trying to be inclusive. We're including everybody, not just people that have access to the technology, but also people that don't have access to technology. Most of the feedback I get from patients is, wow, that's easy.
This is a free service for everyone. If you're worried about your virtual care appointment, we're here to help you.
You don't have to worry about the technology. We can do this for you.
So just wanting to thank everyone for taking a look at that. And if you're interested in leveraging or using digital navigators, there's a few ways to contact them as well. Did want to also just say we are also supporting patients and caregivers by offering education for free in the London community. In the last year, we completed 29 of these virtual healthcare workshops, which are 90-minute classes that you can attend in the community to learn more about virtual care, what it is, what supports and resources are available, and you can even practice a virtual care appointment in that workshop, just to give people more comfort with virtual care. So there are some upcoming community classes, and I would encourage you to reach out to the organizers if you're interested in joining. And lastly, just wanted to mention some work we're also doing with improving patient communication. As part of our community survey, LHSC did commit to allowing patients to opt in to receiving administrative messages via email and text. And so in order to support that work, we've added a new field to OneChart to our electronic health record to capture the patient's preferred communication method for administrative purposes. And to date, we've had 30,000 patients' information collected, and overwhelmingly, patients are preferring phone, text messages, and email for receiving administrative messages. Actually, less than 1% of patients prefer to receive information via letter. So we are socializing that information and providing supports for staff to encourage them to reach out to patients in their preferred contact method. And that's it for my update, and I'll pass it back to David.
Thank you, Narissa. So before we close, I want to remind everyone, we have a web form available for you to submit questions to be answered in these meetings. You can find the link in the description on the YouTube page and on the Community Update Meetings page of our website. And we also have a QR code up on the screen right now for you to scan, and it's going to take you right to that form to submit questions. So since our summer pause, we have not received any new questions. So I really want to appreciate your engagement and encourage you to continue submitting any questions you may have. They really help us ensure we're addressing the topics that matter the most to you. And I really want to thank everyone for tuning in. Now, to our media partners, please join us now to our media scrum, and we look forward to addressing any questions you might have. Thank you, everybody, for joining us today. Have a great October. Happy Halloween. Take care.